Everyone, thank you so much for joining us after lunch. I hope you're all fed and caffeinated and have used the restroom and are set for our last two presentations. Our next presenter is Dr. Diana Carvajal, presenting Equity, Justice, and Contraceptive Care. Dr. Carvajal is a practicing family physician and clinical researcher in the Department of Family and Community Medicine at the University of Maryland School of Medicine. She's an assistant professor and is the research section leader in her department. She is the director of the Reproductive Health Education in Family Medicine, or READY program at the University of Maryland Family Medicine Residency Program, and is the director of Diversity, Equity, Inclusion, Anti-Racism, and Strategic Planning at the National READY program. Her research focuses on Latinx populations and contraceptive decision-making. In her work, Dr. Carvajal strives to use the frameworks of intersectionality and reproductive justice that recognize historic and current injustices perpetuated against marginalized people. Dr. Carvajal, thanks so much.
Hi, everyone. Good afternoon, and thank you, Dr. White, and the rest of the PICCK team for having me. I'm really happy and excited to be here today at this conference. So in the next 35 minutes or so, I am going to talk about equity, justice, and contraception care. But I just want to say that it's very much from my perspective and my own lived experiences, not just personally, but also in my clinical work and my teaching and the research that I do. So I like to frame it from the beginning when I talk about justice and equity in contraception, that this is very much from my own perspective. I have no disclosures. And so, you know, as Dr. White shared, my lenses often really try to look back and include some historical context. So I think, you know, before we talk about contraception care in the context of equity and justice, the importance of historical context, at least for me, is really critical. And especially if you're unaware, or if maybe you don't remember reading about this or learning about this during your medical training, probably it never happened, but it's still key and critical. And so, you know, today, especially for me, as we grapple, I think, a lot with recent reports at ICE facilities of migrants having unnecessary hysterectomies or unconsented sterilizations, I think, you know, I've heard it causes a lot of outrage, I think, for people thinking that this kind of thing is so atrocious and it happens in the 21st century. But it's actually really not that new. And for a lot of us, not even very surprising. Because American history has a long-standing, I don't want to say tradition, but a long-standing truth of devaluing the bodies and reproduction of Black, Indigenous, immigrant, people of color, and certain people with uteruses. And those things have manifest themselves also with eugenics policies aimed toward people with physical, psychological, and cognitive disabilities. And we see those things happening with movements that we call population control, but also with reproductive violence, forced sterilization, and experimentation. And these things date back to Native American populations back in the 18th and 19th centuries. What we know is that there was a devaluation of their traditional either feminine leaders or leaders who were women who had uteruses, who were often at the center of communities and were very often viewed and treated as the leaders of those communities. And there were often concerted efforts to devalue those feminine leaders, often by religious missionaries or other government officials or representatives. And this was really done in an effort to usurp power. There were forced migrations of Native American populations that were very brutal and often forced pregnant people specifically to travel under harsh climate conditions and even oftentimes during labor. And a lot of these circumstances were created sort of purposely to interrupt traditional birthing practices and rituals. And during these forced migrations, what we know is that many people died, many people with uteruses died, and this led to what we know of as a mass genocide of Native American populations. Into the 20th century and up until the 1960s and even the 1970s, Native American people with uteruses endured forced sterilization. And this happened to almost 50% of Native American people with uteruses between the ages of 15 and 45 at the hands of the IHS. So when we think about our enslaved African Americans, which I think many of us feel like we know a lot of this history, but what we know is that very early on, there was abuse and forced, African-American enslaved people were forced to have the children of owners for profit. This continued on until emancipation, when the reproduction of African-American people was actually no longer profitable to the white cis male supremacist culture. And so instead there was a reversion of labeling African-American people as being unfit parents or unfit mothers. And this was really because they sort of were no longer valued. Their children were no longer valued. And by the end of the 19th century in America, what we have is contraception and abortion criminalized. This was across the nation, and it was really done in an effort to control the fertility, specifically of white cis women. In other words, the children of heterosexual couples, white heterosexual couples. And I say this because has also emerged this concept that applied for women of color and also people of color, that sort of they were kind of beneath the law, so that the laws that were being reinforced when people were using contraception or having abortions really didn't necessarily apply to people of color. And this was really because their reproduction was no longer profitable, and their bodies were sort of like not even worth policing, right, in this case. LGBTQIA folks, as we all know, have been enduring the same degree of inhumanity for centuries, including the denial of basic human rights, but also denial of reproductive health, criminalization of sex, love, and marriage. So just to keep going a little bit with the context, and I know it's a lot, but to focus on sort of the context for some Latinx populations, we know that from 1920 to 1949, California eugenics laws actually allowed, sanctioned the sterilization of institutionalized patients. And it just so happens that Latinx folks were actually disproportionately sterilized. If we move on and think about Puerto Rican populations as well, in the 1940s, there was a government-supported, sanctioned sterilization campaign that was for population control. And during this time, Puerto Rican people with uteruses were consented for sterilization during labor. And by 1965, 35% of people with uteruses in Puerto Rico had actually been sterilized, and 2/3 of them were in their 20s. And today what we know is that Puerto Rican people with uteruses living here in the US on the mainland have actually the highest rates of sterilization of any other group. And in the 1950s, when I think, a lot of people were sort of feeling happy or liberated because contraceptives were coming to the American market and they were really meant for use by cis women, we actually know that several of those methods were tested first on folks in Puerto Rico without their clear consent and before being declared safe by the FDA. So that the FDA finally did approve them, and only after the FDA approved them were they distributed here on the mainland in the US, but previously were tested on Puerto Rican people without their consent. Mexican origin women and people with uteruses, so much like today in the 1920s, there was a sort of a national debate about immigration and how immigration is potentially a threat, or how it might actually be imposing, right, on sort of the racial stock of the nation. And Mexican people at that time specifically, and their children, were really targeted for assimilation and adoption of the values of the mainstream culture in America. In 1969 to 1973, Mexican origin people with uteruses were sterilized without their knowledge. This happened at UCLA Medical Center. Some of you probably have heard and read of this. But the unconsented research on contraceptions with this population went all the way through the 1970s, actually. And our anti-immigration policies throughout history have really been clear about whose bodies and whose reproduction is valued. And they go back all the way to the 19th century against Asian Americans, mostly Chinese and Japanese. There were bans and restrictions on immigrants bringing in their wives or their cis female partners so that they wouldn't have children here in America. And we have our modern day examples as well, right, of immigration policies that interfere with asylum policies that are directed at people from Mexico or Central America or other sort of non-Nordic immigrants. And another famous example is sort of this Muslim ban that was really targeted toward people from specific Muslim countries. So modern day contexts are still going on. A little bit more context here, and I bring up this idea here of contraception as a poverty reduction strategy for a very specific reason. So I love talking about this, and I've been talking about my work and my research for a couple years, and I often give talks that are just like this. But within, I think it was a couple years ago, I was giving a talk, and I was really excited to talk about my work and my research and all the things that I found and how I thought it was really important for specifically person-centered or patient-centered care. And so I was really excited about talking about that. But the person that was speaking immediately before me was also very enthusiastically talking about contraception as a poverty reduction strategy. I thought about it and I thought, I don't know if that really falls very much in line with patient-centered care and what I feel like I'm about to talk about. So I decided I would read a little bit more, do a little bit more research, and try to understand poverty reduction strategy that includes contraception. And so, as it turns out, what I found was that contraception really has been touted as a poverty reduction strategy since the early 20th century and was revitalized actually by the LBJ administration. It happens to be part of the 8 Millennium Development Goals, the Millennium Development Goals from 2000. And really outside of the US, it's often targeted and talked a lot about in low and middle income countries as a method of reducing poverty. Mostly, and a lot of times, those countries are in Africa or in Latin America. And they are often contraception as a poverty reduction strategy is, the target of lots of philanthropic giving. But as I thought about it, I thought, so is it really the case that just facilitating a way for people to have fewer children is going to address what I think are some of the underlying structural and systemic racist policies that we have in America that are associated with poverty or probably the cause of poverty, right? The social, economic, and political injustices that have existed for centuries and now in some cases have become institutionalized. Does using contraception as poverty reduction really take into account those historic and current injustices, right? Things like unequal housing and unequal access to healthcare and education and healthy food and imprisonment and police brutality, right? Can those things are those things really being taken into account, or is contraception as a poverty reduction strategy actually failing to address those things? And beyond that, I think what really bothered me about this is that I think that this can really actually start to perpetuate some of the deeply ingrained white supremacist ideology that the fertility and children of others are not valuable and they need to be strategically reduced. So contemporary context, I think, is also really important. And can sometimes, I think, this idea of contraception as a poverty reduction strategy sort of bleeds into this. And so when it comes to contraception and reproductive health and sexual health, the literature, specifically about cis women of color, is telling us that they are more likely to report coercion into choosing very specific methods of contraception, usually LARCs. They are reporting shorter visits with their providers about contraception and contraception counseling. They are also more likely to report perceptions that they feel that their provider has a desire to restrict their childbearing, and that's often because of race or ethnicity or SES or language. And additionally, they're less likely to report actually patient-centered care and an understanding of the method being used. For LGBTQIA identified folks, the literature also shows that they are more likely to report discriminatory comments and treatment when it comes to reproductive health. We know that 1 in 3 trans patients are turned away for healthcare, including sexual and reproductive health services. There's a report also that there's a lack of provider competency in reproductive health, which I think is not that surprising for a lot of us. And then the NSFG, the National Survey of Family Growth, when they specifically identified lesbian women, that's how they were identified, were less likely than heterosexual women to report getting contraceptive counseling and prescriptions, but also more likely to get STI testing. I just bring all these things up because there are a number of marginalized identities here, and these intersect, and the layers of oppression sort of intersect when we think about race, ethnicity, religion, language spoken, whether somebody's able-bodied or their gender identity. And the more layers are, the further marginalization there is, and the further we're starting to get away from inequity and from equity and justice. And I think this is important when we think about our patients and the kind of contraception care that we're providing for them, particularly when we're really trying to think about historical and current context, and providing the best care for them. So this is also contemporary context, right? And I tried to talk about the larger framework and the context of the continuous sort of violation of human rights that I feel like we live in, and specifically our poor or our marginalized patients are living in. I mean, the current context in America is that we have unequal access to healthcare and public education and nutrition and housing and legal services, right? And police protection, while we're disproportionately over-policing certain communities and murdering them. And in a current context, COVID-19, right? What we know is that Black and Latinx populations are 3 times as likely to be infected with COVID-19 compared to the white population. 31% of Asian American adults since COVID-19 began report being the subject of racial slurs that are specifically about COVID-19. Those of us in medicine and healthcare who identify as people of color or Black or Indigenous or underrepresented in medicine are experiencing, I think our own social injustices and inequities in healthcare. We know that the rates of URMs entering medical school in particular are stagnant. They really haven't changed at all, and in some cases are declining since the 1970s. And we also know that URMs are less likely to be promoted and have leadership positions, and more likely to report microaggressions and macroaggressions and discrimination and racism. So I say this because I think this is all important and part of the context as we take care of our patients, and we really try to center equity and justice. And so the frameworks that I like to use and I think about as I practice and teach and do research in reproductive health and contraception counseling includes all of these things that I have here: autonomy, equity, and justice. And if these aren't new concepts, and definitely, they're not my idea, right? They stem from a much larger framework of human rights that a lot of people have been talking about for a while. And for me, it's really important to keep these things in mind. And it's moving sort of beyond just respecting a person's individual decision about about using contraception or not, but to really understand the social supports I think necessary for individual decisions to be optimized and realized, and to include a framework of human rights, which I think is really, really important as we think about the care that we deliver. So this is a word cloud just from an online program that I used because I was thinking to myself, patient-centered care, that's what I think we have to do for equity and justice. What is it? Who wants it, right? What does it matter if we're thinking about equity and justice? And so these are just the words that I put into the word cloud, and this is what came out. And this is really my personal take on patient-centered care that I'm going to talk about in my research, and that is really, really grounded in the clinical work that I do, but also, full disclosure, in my lived experiences. So my research context, I think, Dr. White mentioned it and I mentioned it, is justice-based lenses and social determinant of health equity. lens that I try to keep at the forefront of the work that I do. But also, if I'm being honest, right, I also identify as a Latina cis woman whose parents are immigrants from the Spanish-speaking Caribbean, and who's here, in the U.S., born here, trying to do this work, but also who has her, my own experiences as a clinician and a researcher and a teacher. And often, what I've always lived with are these, what I think are these sort of persistent stereotypes about Latinas or Latinx populations. And this is really sort of, these are the things that kind of led me to really want to do this work. For Latinx populations, I think there's often this dichotomy of, them being either very religious, hyper-religious, so religious that they can't use contraception because it's not what they believe, or this hypersexual, sort of hot person who is, running around having lots of sex, and it's heterosexual sex, and it's very feminized, and these same people are very dominated by heterosexual cis men and quite incapable of using contraception or planning ahead for that matter, especially when it comes to their childbearing. And that in some current contexts that we often hear about in terms of immigration, sort of this demonization of Latinx folks, right, as coming here to the US or crossing the border illegally just so that they can have children here. There's this concept of sort of anchor babies that often pervades, I think, stereotypes and typecasting of Latinx populations. And then, there's this research that I presented previously about continued experiences of Latinx patients and other marginalized people of coercion, particularly surrounding their fertility. So I'm going to just tell you a little bit about some of my research findings by reviewing a few studies. And I'll start with the first one here, just name them 1, 2, 3, I'll talk about them here. And this study is a qualitative study that we did with people in Baltimore who self-identified as Latina. I will say we actually did not ask specifically about gender identity, but they did identify as Latinas. And so this, with this population, we really wanted to know their perspectives about, one, the factors that influence their contraceptive decision-making. That was the first. And then the second was that we really want to know their perspectives about the role of healthcare providers in facilitating that contraceptive decision-making. And we wanted to know how the patient-provider relationship in terms of communication and trust really impacted that decision making. So that was the question. And this was a qualitative study that we did and did back in 2015, where we had self-identified Latinas. Their ages were 15 to 24. We recruited these participants specifically from a few federally qualified health centers in Baltimore, where there was full spectrum care, including reproductive health and primary care. And we conducted focus groups and interviews with these participants. So this is a busy slide, and I'm not going to read the quotes that are examples of our themes, but I'm going to talk about the themes because I think that they're important. And for me, were sort of eye-opening, even though they might not seem that novel, right? So the first theme was really this desire to avoid pregnancy at specific times when it was right for them. And that was really, not surprisingly, the driver of contraceptive intentions for them, which all seems really obvious, right? But for me, in thinking about the stereotypes and the history of forced sterilizations and the notion that there are clinicians who are imposing their values on patients when it comes to contraception use, I remember not just stereotypes growing up, but also learning as a learner and hearing from providers that, unintended pregnancy and preventing it was so important. So we had to really help patients decide and convince patients that they had to use contraception, right? And it felt to me often like this was what we were learning, that we had to convince people to use contraception. They really needed to know that because it was really important for them and it was going to make them so much healthier. And what this brought to the forefront for me was that people don't have to be convinced. This group does not have to be convinced. They have figured it out and they can make their own decisions and they know when they want to use contraception or they don't want to use contraception. So that was the first theme. The second theme was really that these participants found the role of providers in contraception decision-making really to be about building trust and strong relationships. And they thought that communication was so key. And by the way, weren't always getting it. The third theme was about using a patient-centered approach, or using this shared decision-making approach that we talk about all the time. Patients didn't use those words at all. The participants, they didn't use those words, but they kept talking about all the things that I think encompass patient-centered care. They talked about wanting information. They talked about wanting providers to ask them about their preferences. They talked about wanting to engage in conversation and get information about side effects and have guidance specifically from their providers about, based on their preferences. So for me, that was patient-centered care and shared decision-making. And then the fourth theme, for me was about some of the sort of misconceptions and themes that I talked about, which was that, one, they very much countered the idea that there was any religious ideology that was preventing them from using contraception. And also that, what are sometimes considered as the norms in their society, or the influences of either their partners or their friends or their family, that those were also did not operate as barriers. And it wasn't just that they used contraception or didn't because there were norms in their society or people in their communities telling them not to use contraception. So for me, again, I think that was sort of busting a myth that I think I've heard pervasively out there. So, and lastly, I did want to share this one specific quote, which to me really illustrated the importance of patient-centered care and focusing on what the patient is asking for and what the patient is telling you about themselves. And really hearing patients, I thought, really is key, right? And so this quote illustrated how I think participants were feeling in some cases about patient-centered care. This wasn't the only one, but it brought to me, to the forefront that patients talked about this. They really wanted their providers to avoid typecasting them or prejudging them based on their ethnicity or their language. And they wanted clinicians to get to know them first and ask them about their preferences before making assumptions about what methods, if any of the methods, were best for them. And they really equated this with communication and trust. There was really this consistent expression of frustration with clinicians who they perceived as being paternalistic or imposing certain methods on them, and at the same time ignoring their preferences. As you can see from this quote, there were people who expressed being prejudged and discriminated against because of race or ethnicity. That wasn't necessarily just, for this population, even based on a difference in language. So for me, the conclusions here were there are clear motivations for wanting to use contraception. There's a clear desire for effective communication and trusting relationships with clinicians. But there were barriers too to patient-centered care. There's poor communication and coercion and sort of race and ethnicity-based judgment that really was a problem for contraception counseling for these particular participants. But also it really came to the forefront that clinicians can facilitate contraceptive decision-making by using a patient-centered approach. I'm gonna talk a little bit about study 2. And so just, to say that the data collection with this population is ongoing, and the conversations that we're having with the community of Latinx folks in Baltimore is ongoing. So as we continue to have these conversations, there are other themes that emerge from this data that I think really reflect lived experiences of both the participants, but, also in some ways of my own as a Latina clinician researcher. And for me, brought some sort of, I think, the counter narrative to some of the existing stereotypes that I think, are out there. So the first was this idea of contraceptive agency. This data really showed that participants claimed autonomy over their own bodies, right? They felt like they were in charge, and that it wasn't the church or it wasn't parents or friends or partners that made the decisions for them, but that they made their own decisions. They also talked about, and I termed it aspirational capital, but it's not the term that they used. And it's also not a new term. It's a term that was coined by Tara Yoso, if anyone's familiar, who uses critical race theory in her work. And she defines aspirational capital as the hopes and dreams of people and their families as they continue to sort of have aspirations for high educational goals and career goals. And this is all despite persistent inequities that they face in America. And it was a term that was really used to describe African American youth and Latinx youth who are in this country and still have aspirational goals and aspirational capital despite the inequities that persist. And in this case, this was definitely something that was brought to the forefront by these participants. And then for me, this last one, the sense of community obligation is a counter to this idea that, you know, Latinx people are here and they come here and they want to have big families all the time because it's part of their culture and it's ingrained in them. And this theme sort of countered that in a way, because what continued to come out consistently was what was described as a sense of community and of obligation to the well-being of their own families and their communities. And in that there was caution that they felt that they actually not only didn't always want to, but that they always couldn't have large families in the current context of social and economic and political inequities and situations that they were facing here. So I thought that was an important theme to talk about too. And overall, I mean, the implications of this work, I think, is that participants claimed reproductive control of their bodies and found that contraception was important at some times and other times it wasn't. And this is for achieving their goals, but they also felt a strong sense of obligations to their own community and their own well-being because of the current context. And that in many ways, this really, I think, counters some of the typecasting and myths and narratives about Latinx populations. One, that they're all the same, right? That they all come from the same place. And two, that they don't want to use contraception or they can't use contraception or that they don't have aspirational goals. And so in practice, I think it's important to recognize that the patient-provider encounter should include communication and should focus on eliciting and understanding patients' preferences and their lived experiences, especially for supporting vulnerable and marginalized populations, and in this case, Latinx populations, and really supporting their decisions. And I think it's important too that we really think about our own biases as clinicians and really try to check those when we come to the table to talk with our patients. So in the interest of time, this is the third study and I'm going to talk about it briefly, but I want to say that it's really built on the formative work of the first couple of studies that I talked about. And this aim, we wanted to develop a patient-centered and a patient-responsive set of survey items that we could use to measure factors that the population really validated as influencing their contraceptive decision-making. And so what we ended up with was 27 items that were content validated by this target population that reflect what they told us are the important factors and the relevant contexts affecting contraceptive decision-making for them. And this is for our Latinx patients in Baltimore. And so you can see here, there's a list of factors that, you know, they described as being important, and we have created, again, content validated items, survey items, quantitative items for use moving forward in future studies. So just again, for the sake of time, I know I'm going a little fast here, but I just want to say that the implications, I think, of the study with our quantitative items really is that, number one, I think it's one of few studies that really looks at the factors that are related to contraceptive decision-making for this marginalized population that really, I think, incorporates their voices. There are not a lot of them. It reinforces that patients and their context really mattered for patient-centered care if we're gonna really achieve that. And what we plan to do in the future, we're working on now, is evaluating interventions that are designed to improve contraceptive counseling with Latinx folks and using those items to do that. So I think, so that's what those were the implications there. My personal takeaways from the work that I've been doing and these are, they're not complex or innovative, but they're mine, and they really came to the forefront for me, is one, that contraceptive counseling is really not always patient-centered. Also that access and autonomy are not mutually exclusive. And I really think that we have to think about those two things together as we move forward to provide just and equitable care. And also that we should trust our patients, all of them, because I think that's really important, and I'm not so sure that we're doing that. So for me, what does it all mean in the context of clinical care? And these are just my thoughts and lessons that I really try to live by and practice as I do clinical care, but also as I teach and I do research. I think I've mentioned a bunch of times that I think grounding in historical and current context is critical, but also communicating and building trust with patients. I try to build trust with my patients like I would want it for me, because I think it's really important in terms of getting patients what they need, I think, and what they want. Shared decision-making, patient-centered care, it's important. Elicit from people what they want and what they need, and really work hard to try to give them that. And I think that we can do that by really supporting and optimizing their autonomous choices. Avoid typecasting and coercion. That's what I really try to do. And don't get me wrong, I'm not saying it's easy. I think that it's really hard for us to check ourselves and sometimes unlearn some of the things that we've spent our lives and sometimes our entire careers really learning and thinking about it as truth. I think it's hard to undo those things, but that's why I think historical context is really important. And lastly, and I said this before, again, access in isolation just it's insufficient, and it's not enough without autonomy and justice. And it's really because I think the ability to have autonomy over reproductive health and childbearing is so deeply embedded with and determined by the myriad of structures and social injustices that exist in America. So it's important to recognize those, I think. Patient-centered care, thinking about it maybe as patient-led care. And this is not something that I coined at all. I actually heard Cherie Scott, who's the CEO of Sister Reach, say this in a panel that I was on with her. And it really struck me, because I think centering patients is really important, but also letting them lead their care is really important as well, I think. Listening to people and hearing them for what they want, I think, is really crucial. And sometimes that means that we have to talk less and judge people a little bit less, and also believe them. I think that in healthcare and reproductive health is no different. We're always judging what we think people need or what we think they know. And the number of times that I have heard from a learner or from a colleague that, well, this patient's a teenager, or well, she's got lots of kids already, or they can never remember to take a pill, so I think they need X, Y, or Z method. The number of times that a person of a marginalized group, a poor person, a person of color, or an immigrant or any other marginalized group, is the person being talked about is 100% of the time in my experience. And so I think it's really important to, again, not typecast people, believe them, and recognize their own autonomy and really not interfere with it. So just a little bit current and future directions that I'm going with this research. We are now actually doing some work with providers and getting provider perspectives on their counseling and what they think patient-centered care is and how they counsel, and sort of a number of other perspectives about contraception counseling and what they do. And then we plan to actually observe those interactions between patients and clinicians to, as objectively, as possible, really measure what's happening in terms of patient-centered care and shared decision-making. And our plan is to start focusing our outcomes much more on patient satisfaction with the counseling and with their chosen method instead of traditional measures like unintended pregnancy. And ultimately, we want to develop a tool that is really focused on engaging clinicians. So it's a provider-facing tool that is focused on having clinicians engage more in shared decision-making or in patient-centered care. So this is a list of resources which I think will be available on the Google Drive with the PICCK team. So I'm not gonna leave them up too long, but they're there if anyone's interested. These are some acknowledgements. I really have to acknowledge the Latinx population in Baltimore that I work with, which is so fun and engages me every day. Also, my collaborators who are listed here, and the patients and staff really of the healthcare facilities where I recruit patients from. Because I think, I often help, but a lot of times hinder the progress toward justice and equity. And I'm trying to work hard not to do that, to hinder anymore. And then also the funders of the work. So these are references also available through the Google Drive. And I will leave it at that. Not quite as many minutes for questions as I wanted, but there's some. So thanks, everyone.
Thank you so much for that presentation. I think it was so helpful to think about how to counsel and think about the historical context that patients enter the room with. We are getting questions for you. So the first is, should patient-centered care always be through shared decision-making? I've heard some providers say that some patients genuinely do not want shared decision-making encounters, and the asker pushes back on that. What are your thoughts?
Yeah, I think that's a great question. And I talk about this actually frequently because, shared decision making, we think about this as it's completely shared between the patient and the provider. Is that always what the patient wants? And what I would say is that this equal decision making between patient and provider is not always what the patient wants at all. Sometimes the patient really, depending on their experiences, lived background, the patient wants something else, right? The patient wants you as a provider who they trust and they've been communicating with to help direct them a little bit more in that direction. And I think that's okay. I think that's still patient-centered. It may not be exactly what we call as shared decision-making, where it's equal between a patient and a provider, but it's still patient-centered and it's still honoring a patient's preferences. And so I have no problem with that. And if that is what a person is coming in the room and telling me that they want, then that's what I work toward for them. And it doesn't mean that I have to impose my thoughts or values on what they want, but it does mean that I can help guide them and use my knowledge, right, and my position of privilege really in the room to help guide them so that they leave thinking, this provider gave me exactly what I wanted. I wanted them to guide me, and they did that. And I feel more satisfied with the visit and with the method. And I think that's ultimately where we want to end up. So that's what I say.
Thank you. We have another question about when providing contraceptive counseling to a person who's had multiple children. Do you have any thoughts on making sure that we are appropriate and non-coercive with those patients?
Yeah, I mean, one thing I would say is that I don't think that the approach is different for people who've had multiple children or people who haven't had multiple children, right? I think the approaches should generally be the same, which is that we focus on their preferences. I mean, so the multiple children thing may come up, and it may come up from the patient. Hopefully that's where it comes up from. And patients can say to you, I have a number of kids and I don't want to have any more children. And so therefore I want to use the most effective method, let's say. I think if patients say that and that's what they describe as being their preferences, then that's where we go with it. But I think letting them lead the conversation and having them tell you what they want is really the key. And I'm not so sure that having multiple children versus not having multiple children is necessarily the place to focus on, but rather what the patient is telling you they want and what they're saying is best with them.